This conference will now be recorded.
Yay.
Good job.
Okay, this is the ANCAN High Risk Advanced Prostate Cancer Support Group for October 3rd, 2022. We want to open the meeting by acknowledging our sponsors, who are, hold on a minute,
Just remarkably strong for
Bayer and Pfizer. Thank you,
Good
Bayer and
job.
Pfizer, supporting this group.
Good job.
And for Rob, to just give you a little orientation, this is usually a 2-hour group. We tend to focus a lot about treatment and treatment decisions, but we're open to talking about anything. And our mission is to both guide and support each other as we go through the prostate cancer journey. Everybody here on the group has prostate cancer, and there's probably many people who have gone through, for you and James, what you might be going through now. Now, we usually start the group by introducing new members, getting some background information on you, which we will keep track of, if you don't mind, and ask you about in the future, so we have a little bit of background. Is it all right with you if I, Rob, ask you a few questions for background information about your disease?
Sure.
Okay.
Yep.
So it's Rob Glover, and how old are you, Rob?
60.
Where do you live?
Southern Colorado.
Okay. And are you new to the game, or have you had prostate cancer for a while? When did you get diagnosed?
Diagnosed originally in June of this year for the first time.
You're
So
pretty new. Okay.
I'm pretty new.
So
Still going through some testing, so I have not yet gone through any treatment.
no treatment yet. Okay. So June of 2022. And when you got diagnosed, what did they tell you about what you had?
Yeah, there's a story about, they told me what I have then, and a story about what I was told just about 2 weeks ago, which are not the
Okay.
same story.
Tell us both stories, if you don't mind.
So the first story is the PSA I had was originally a 10, and then 2 months later it was a 12.8. Biopsy, according to my local urologist, was a Gleason 7, 4 plus 3. I don't remember the count in some of the cores, 3 plus 4 in several others, and 3 plus 3 in all the rest. So it was pretty much spread throughout. So I was originally diagnosed as just intermediate unfavorable, is what my urologist called it.
Okay.
After reading probably more than I should on the internet, I decided to request a second opinion on the biopsy from Johns Hopkins. When they read it, they saw 1 Gleason 9, 3 Gleason 8, all on the same side, and the rest were a mix of 6s and 7s for all of the rest on both sides.
You had a little bit of Gleason 9.
A little bit of Gleason 9, yeah.
4
So I
plus
was trying
5?
to figure. I'm sorry?
4 plus 5?
I'm looking at my notes and I don't think I wrote that down. I don't know if it's
Okay.
4 plus
That's okay.
5 or 5 plus 4. So
you thought you had Gleason 7 prostate cancer. Somehow you got onto the fact that Johns Hopkins is considered an expert second opinion for prostate biopsy, and they scored you a couple of notches higher at a 9.
Yeah. Second opinion with a second urologist at a cancer center in Denver. Was able to look at that and look at a prostate MRI. So, it looks obvious that it's, spread throughout the prostate, right up to the margins. And he's concerned about a couple of lymph nodes as well. So that's kind of where I stand at the moment.
Okay. So who do you consider your doctor to be now?
I had gone to this cancer center in Denver, which is about a 4-hour drive for me. And in terms of urologist, he would be the one I'd go to now. I like my local urologist, nice enough guy, but his office is very dysfunctional.
Who's the Denver urologist?
The Denver urologist, it's a Dr. Maroney.
Oh, yeah, we know Moroni.
We do?
Yeah, yeah, we've had guys who have seen Moroni before. He's at University of Colorado, right? He's a CU guy, isn't he?
UC Health and Highlands Ranch.
UC Health. Yeah, yeah, he has a good rep. So we refer guys to him, but please go ahead. Sorry. And Rob, you may be able to get your video on right now because I see a couple of eyes dropped. See if you can see if your video will let you on now. There you go.
Oh, there we go.
There you go.
Oh, I'm here.
Okay.
So second opinion urologist, after a long chat with him, talking about what I have and going over bone scan that I had, he wants a PET scan, PSMA.
Right.
PSMA
Now
scan?
I had met with a radiation oncologist before we got to Gleason 9, when we still thought it was a Gleason 7. He had ordered a PSMA, which my insurance, promptly denied and said it's not medically necessary. Dr. Maroney thinks it is medically necessary and promises he can get it approved.
Yeah.
So that's where I stand
Okay.
now. I'm waiting for it to be approved.
So far you've had a biopsy and an MRI, maybe or maybe not a bone scan.
I had a full body bone scan that didn't show anything, according to my local urologist, and Dr. Maroney didn't see any difference there.
Have you
CT scan as well.
Okay. Had any of these guys do any genetic testing yet?
I actually just got some genetic tests. Did one through there's I forgot what it's called, promise.org or cancer.
Promise.org. Yeah.
You know what those are? Okay, I figured people on this call would know that. And they offered the free genetic test to see if I'd be helpful for their study.
Yeah.
And it did not find any genetic mutations in the tests that they do.
Okay. And of course, that they were testing your genes that were passed down from your parents and passed down to your children. They were not testing the genetics of the cancer itself.
No.
They were testing your genes. So it sounds like you don't have any real concerns about passing it on to children, but did you have any family history of prostate cancer?
My family's kind of spread throughout the world. But I do have an ancestry that has a predisposition of it, which Ashkenazi Jewish ancestry.
Okay.
I do have some first and second cousins, women who have had breast cancer, and I know it's kind of a related gene, from what I understand. Not my area, so I may not understand it well.
Not the genes that you inherited from them, though, because apparently those are negative. But sooner or later, you'll probably getting some genetics done on the tumor itself, and we'll see.
Yeah.
What's there. And so tell us how you're doing with all this and what questions you've had and why you came to us and how you found us.
Well, I found this site. I forgot some reference in my internet searching, and actually was going to go to the other one, the lower risk one originally, because I thought it was Gleason 7 and didn't
That's
seem
right.
quite as bad. But once I switched to Gleason 9, I decided to come to this one instead. I am still looking at. I don't know that I've fully sunk in what all's involved. I mean, I've read about it, but I hazard to guess that there's more than a few people on this call who, have gone through experience of treatment and probably may concur that reading about it's probably not quite the same thing as actually going through it.
Probably about 42 people in this room would agree with you.
So I know I'm in for some interesting times. At this point, I mean, from my discussions with Dr. Maroney, he himself said he would recommend going through radiation treatment.
Okay.
So I thought that was telling coming from a urologist whose
Yeah.
specialty is in surgery.
Well, he probably said that because he figures he might not be able to cure you with a prostatectomy. You have a high Gleason score, which, as you already know, means that you have a somewhat potentially aggressive cancer. And you also have an MRI that suggests that it's pushing up against the margins, and you have maybe or maybe not some lymph nodes. So pulling that all together, your urologist probably thought he was not going to be able to cure you with surgery and want something that will cover a wider area.
And that's what he said. He said, if I go through the surgery, odds are pretty high, like 99% that it's coming back. So, yeah, so that was pretty much this.
And Rob, you can actually run a nomogram. Are you familiar with what a nomogram is? Have you run across nomograms yet?
I have not.
Okay, so I'll put it in the chat window for you. The chat window, by the way, is the little bubble right at the top. And there are many nomograms. They're essentially what they are databases of people who have experienced certain protocols, and those numbers are collected and collated, and then you can jump into that particular database and see what happened to people who had similar disease demographics to you. Somebody, who was that kindly, George, thank you, George. George Rovder put the nomogram in. So if you click on that link in the chat window, it'll pull it up, and you'll need to have your biopsy report in front of you, but it will tell you how likely it is that surgery alone will be sufficient for you. In my own case, it told me that there was a 30% chance that surgery alone would be sufficient. And so I was a little bit younger than you when I was diagnosed, but I didn't want to roll the dice for that chance. And so I decided to do radiation and hormone therapy. And that's probably what Maroney's thinking. And it's possible still that you may be able to get a really good and durable result. But I think that the first thing that was on my mind is, are they going to run a PSMA? And they will, and you won't have a problem getting that approved as a Gleason 9. As a Gleason 7, it takes a little more to get it done. If you're very high volume, you could have appealed it, but as a Gleason 9, I think Maroney's correct. The one thing that I would suggest to you, if you're going to get this, when you get this PSMA, is to request if you can ask him to do the Telix. That's Telix. I'll put it in the chat window. Telix is the manufacturer, and the name of the scan is Illuccix. And we kind of like that the best of the three because you as a patient can request a reread on that. We don't know the level of experience. It's probably pretty good at UC Health, but we don't know it for sure. And Telix offers an overread, and the other two companies do not. And that gives you a little bit of assurance if you have any doubts. They probably will have a choice, and if you can get the Telix scan, you're going to be a little better off.
Okay, I'll have to look at it. If it's approved, it's supposed to happen on Wednesday. But given that it's been disapproved or denied, it's actually been denied 3 times now. And the letter I get from my insurance company always says it's not medically necessary. It has to meet certain criteria, one of which is it cannot. You must have already been treated for prostate cancer before they allow it.
I think that that's highly challengeable.
That's
Because,
Dr. Maroney's position.
yeah, the Condor trial was done precisely for men like yourself, and the approval of the PSMA scan was based on the Condor and the Osprey trial. I think I've got this the right way around. Ben will tell me if I don't. But the Condor was the one for men who were newly diagnosed. And one of the reasons why it was approved was to allow men to make a better decision, which it's since been shown to do. And the insurance company is not understanding that. And you can make a good case. And if you've got a good doc like Maroney, he'll make that case for you.
Rob, what's your current PSA, your most recent one? Is it that 12 that you told us about, or is there another one since
No,
then?
actually, the most recent one was at the end of August. Was 4.5. But
Why did it go down?
I'm told it's because of the medications that my urologist put me on.
Oh, you're on medicine. Oh, okay.
Oh yeah.
Oh, I missed that. What are you taking?
Not in front of me. Remember?
Lupron or
No,
Lupramide
it's not
or
that. It's
Firmagon or Degarelix
yeah.
or
Is it
Orgovyx?
Bicalutamide. Are you on bicalutamide?
No,
Casodex?
Or Govix?
I'll have it in just a second. I know I have it in one of my files here. Finasteride and tamsulosin.
Oh, wow. Okay.
No kidding. Wow.
So,
Interesting.
So it's the
and
finasteride? Okay. Were you
this
having,
overall
do you
process
have
for
some
me.
urinary blockage?
Yeah, that's how I came to this place.
Okay.
So that started earlier in the year, and that's when my general doc sent me to get a PSA test. And when it came back as 10, she sent me over to a urologist who, of course, did a PSA, had me do another PSA test. That ended up being 2 months later. And that's when it went up to 12.8, I believe, 12.8 or 12.28. I don't remember at the moment. But yeah, and then due to other snafus and dysfunctional urologist office, my biopsy didn't occur until the end of May, which is another 2 months later. But when I first saw the urologist or my doc, that was the issue, is that trying to pee was getting harder.
Yeah.
So that was the first things they kind of put me on originally. After they tried a few other things to make sure it wasn't some sort of some other issue and some non-cancer issue, and that didn't pan out. So that's when they scheduled the biopsy.
How interesting that you're on those medicines and that your PSA went down. There's another, besides the urologist, and the radiation oncologist, there's another type of specialist that we want you to know about, and that's called a medical oncologist. The medical oncologist, and in particular the GU, or genitourinary medical oncologist, is the specialist in prostate cancer medical management.
Okay. So I have to figure out how to find one of those.
We'll help you with that.
John, I just wanted to interject and say it's not unusual for the 5-alpha reductase inhibitors like finasteride to reduce your PSA level by as much as half. Rob's case seems to be even more than that.
Yeah.
So I think that's kind of a generally accepted rule.
But it might not be actually killing prostate cancer cells, Rob, and that's where your radiation guy is going to come in.
And Dr. Maroney was very clear about that it's going to lower the PSA. It's not necessarily killing off any of the cancer.
Mm.
So
tell us what questions you have.
I'm kind of somewhat still learning and waiting on this PSMA. To see, have the horses been let out of the barn type of thing already?
That's right. Yeah, probably that's right. All of us have had that happen. I'm also a Gleason 9. There's another kind of scan that you might benefit from being aware of, just in case things go totally wrong with this PSMA scan. But there's another type of PET scan called Axemin, and it's been around longer, and it would probably also give you some useful information about the location of the cancer and the nature of those two lymph nodes. And so if you really completely get rejected no matter what you do, think about asking for this Axemin scan, which is easier to get.
Yeah, that was denied too. But back at Gleason 7 for the same exact reason. My insurance company had the same exact reason for that one as well.
Oh, things will get a little easier once you get on Medicare in 5 years.
There we go. Yeah. So there's that too. So I'm just waiting on this scan. I think like most people, look at going through procedure and side effects, and not really wanting to go through one set of procedure and side effects for surgery, only to have to go through procedure and side effects for radiation right after, soon afterwards. So
John and Rob, there's a bone scan also that might be approved.
He's had it, George.
Oh, you had a bone scan? I'm sorry.
That was approved, and that was done, and so far that didn't look like it. My understanding is it showed that it was clear.
That's good. That makes it very unlikely that you have metastasis to bone. Right. Who can join in and say anything to Rob about your own experience or what you can teach him? Anybody else can speak?
Hi, Rob. My name is Bill. I'm also 60. I was diagnosed a year ago, so I understand the journey you're in. In my case, I was a 7, was a 3+4 before I went the route of surgery, and then after surgery it was a 4+3. I also had the case where my insurance declined the PMSA test as well. I was told it was because, or not from the insurance company, but I was told that it was probably because the PMSA was approved fairly recently prior to my diagnosis, and the insurance company just hadn't caught up. What I ended up doing was I had actually gotten 4 consultations, and one of them, I'm in Chicago, and one of them I had a PMSA scheduled prior to seeing a couple of them, and one of the doctors here had said, well, if you have any trouble, let me know, and potentially, I can get you in a study. And then I found I was denied, and that's how I got mine, was through a study. Now, this study here, in order to qualify, you had to be going down the path of surgery. That was the one criteria. So it's not like your path isn't to do surgery, but I don't know if anyone knows if there's any studies that he might be able to get that covered under.
Yeah,
I
I'm
think
not
what
aware.
people will,
I'm not aware of
sorry.
any studies right now. I mean, we could certainly research it, but I think it's going to be a non-issue. I think that a couple of things occurred to me, Rob. The first is that Maroney's right on the money with this, and he's giving you really good advice. Secondly, if you do what I suspect he would recommend, and the radiation oncologist, whoever you settle on, recommends, you're going to get pelvic girdle radiation and hormone therapy. So you will get treated in those areas. Now, in the areas where we think there could be issues. Now, it would be good to know with a PSMA scan, and you're probably not going to start anything until you've done the PSMA scan. But my guess is that's the treatment that you'll get, and it'll be the right treatment. We'll help you once you get to the radiation oncologist. We'll help talk to you about the options. You've got some guys on here who are familiar with what's going on in the Colorado and in the Denver area. It may be a little tricky to get the treatment that we would recommend, which would either be SBRT or brachytherapy to the gland, and IMRT to the whole pelvic girdle. I mean, when I say recommend, we don't give medical advice, but I can tell you that that's certainly what I would do. And I think most of the guys who have been through it and had some success have done something similar. And that's what appears to be the gold standard. And we can point you to where that is. But I don't want to put the cart in front of the horse, because we'll have plenty of more time to talk to you about this, and we'll hold your hand. I think what is important right now is to settle on a really good radiation oncologist. And that's going to be that's also going to be a little tricky for you given where you live. I mean, it may be possible that you can do some of the treatment in Denver, and then have them coordinate with a local guy to do the IMRT part, because I expect the fancier equipment won't be available. But we have some people here. I know Tom Jacobson, Peter Kafka's a little bit familiar. Who do we have from that Denver area who can speak to radiation oncologists? Anybody today?
Well,
I could
have
speak
met with a
briefly.
radiation
Oh, go ahead.
oncologist. I'm sorry. I was going to say I have met with a radiation oncologist so far, but I don't know much about, choosing one. I just kind of came across one from the cancer center at Penrose Hospital in Colorado Springs, which is, a little bit closer to where I live.
Right.
Tom, did you have something?
Where do you live, by the way? Where in Colorado do you live?
I live in Alamosa in the San Luis Valley.
Yeah, it's a haul. I can only speak from my own experience, which isn't too much with radiation therapy, but I did go for a consult with Patrick Richard, which I mentioned some time ago, and he seemed to be a very credible person. Also, fairly recently, Boulder Community Hospital, I live outside of Boulder, the Boulder Community Hospital has been touting their TrueBeam technology, which I think is a SBRT with a MRI tracking to improve on accuracy. And at least on paper, it sounds like a good thing. It's something that I think UCLA is also doing. So I'm not saying that Boulder is the the end all be all, but it is something that is the technology is fairly quickly expanding, and I think that's a real plus for people who are considering radiation oncology. And personally, after I did my consultation, I haven't done anything with that yet. I don't know why that is. Just I'm sticking to my ADT and letting that go. But if you do want radiation oncology, it's probably worth looking at Anschutz and seeing what they've got. In they're Denver based. Actually, they're in Aurora, but that's closer to you. Not by very much, but it's something. So that's my take on it.
Rob,
Yeah,
before we move on, Rob, I just
professor.
wanted to ask if you could put your email in I mean, if you're going to stick with us, maybe put your email in the chat there, and we'll be able to send you reminders for group. So nice to have you with us. So now for you new guys, what we're going to do is go down the list of regular old guys that want to discuss something about their treatment. And Rick's going to start us off. Rick, by the way, Rob and James, when you hear that London accent, you know that's our founder, Rick Davis. Go ahead, Rick.
Thanks, Dr. John. I just got some more sad news, and I haven't really gotten into it yet, but it was very much expected. But John Birch passed away. I can't even tell you when. I will update everybody through the in the reminders next week. But I see that there's a email in my inbox from Lynn, his wife, with the obituary, so I can't tell you more. But he hasn't been with us now for several weeks, and we knew he was getting weaker. And we've spoken to Lynn in the care partners group, and basically we knew that he was coming towards the end. I mean, he had a hell of a fight for many, 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 many years. Forgive me for anybody who doesn't like that language. I'm sorry, I apologize, but he's been wrestling with this disease for a long time. I think some 20. Dennis McGuire, how long was John?
Hey, Rick. Yeah, John was living with prostate cancer 17 years.
Wow.
And he passed away yesterday. So I want to say some words. I want to say some words about John next week, but
Please.
I'm still kind of broken up.
Yeah, and we'll definitely, and Peter Kafka will make a note, and we will come to you next week. And I did want to offer you and your wife condolences, because I know that you've been pretty close. Both of you have been pretty close to Lynn and to John, and it's been a tough ride, a tough road to hoe, especially over the last 8 weeks or so. I know I'm well aware, and we are well aware. So we we wish you much comfort. We wish the Maguires much comfort as well here, Dennis.
Thank you, Rick. I'll speak more about John next week. Thank you.
Yes. Yeah, please. We look forward to it. Absolutely. Back to you, Dr. John.
Alan?
All right. So last Monday, not this Monday, but the previous Monday, I started the radiation treatment, and I've been having a hell of a time with it. I can't seem to empty my bowels or fill my bladder. And Dr. Michio, I'm getting my radiation up at the Penn State Cancer Institute because it was too far to travel down to Fox Chase. And he's put me on medication. I take milk of magnesia. I take a laxative. I take a whole bunch of stuff. And today we started using an enema. Try and get the bowels empty. I'm a little better at filling my bladder, but the problem is I get it full and I'm leaking all over the place. And today I leaked on the table when they're doing the treatment. And just, I'm fighting it. And then it just says, hell with you, Alan, I'm just coming out. And that seems to be what happens. So I'm pretty, I don't know what else I can do. I'm following all the directions that they give me. Feeling pretty bad about what's going on right now. You go in there every friggin' time and you feel like a failure because they say, well, your bladder, is only at 80%. That's enough. We can do the treatment, but you got to get that thing fuller. It's like, shit, if I did it fuller, it's going to burst. And it's like I started taking the water at 6:30. Yeah, that was no good because by 8 o'clock, man, I was just ready to explode. And I've been taking it later and later. Tomorrow, I'm going to take it at 6:50. So that at least I'm not like having urgency before I get on the table. So if anybody has any ideas, Dr. Correa gave me something. I texted Dr. Correa and I said, give me a bladder training program. Give me some. And he said, yeah, right. That's not going to happen. And so he gave me some medicine to relax my bladder muscles. I think it's oxybutyn. I think that's which one for that. And then Michio up at Penn State, he doubled it and doesn't help. And Michio said, well, take a little Advil. Well, my wife won't let me take Advil. Took Tylenol this morning to help with it just feels incredibly terrible in that waiting room. I mean, I'm just dying in there. I don't know if that helped or not. So there, I just want, there's nobody you can complain to about this shit because, what am I going to do? Tell my sons? They know a little bit, but not really. Certainly not telling people at work. My colleagues, they say, how you doing? I say, I'm doing shitty. The treatments are really tough. They all think it's the radiation, but not the radiation. Radiation I could care about, it's the preparation. So there you go. I just need to whine and cry a little bit and get it off my chest because that's good for me. I'm a talker, and I just put it out there. But there's so many of these things that I have nobody to friggin' talk to about it. I have 3 best friends. We meet every week. I can't talk to them about it. Those 3 guys I can talk to, but there's really nobody else. So there you go. Any thoughts? Fine. I don't expect anything because and this one guy, Ethan, who's one of the technologists, I just think he's great. He just goes, you'll get to it. He's really supportive. He wasn't there today and I hated it. I had 2 women who I didn't find very kind. But when he's there, I feel a lot more relaxed, which means I probably do better holding my urine.
Right. So I have a comment. This is Alan Moskowitz. I take it you're still doing your radiation treatments, right?
Yeah, it hasn't been so bad he can't do it.
Right.
Misha came in and he said, well, here you go. He said, maybe it's protecting your rectum a little bit because this is going here, this is going there.
Right. So look, I had radiation and, I had to have the bladder full, that whole business, just like you're doing now, right? So the key is not that your bladder is so full that you're bursting and uncomfortable. It's more about some level of consistency. Again, that's what I was told. And so what I did was it took a few days, maybe a week, sort of trial and error, how much to drink, what time to drink it, allowing for, 30-minute travel and getting undressed and the whole business. Okay. Now I cheated. Okay. There is a way to sort of cheat, which is what I did after 3 or 4 days. I said, this is no good. I'm too full. I have to let some out, which is not so easy, and still retain it. And I don't want to be bursting. And so what I did is I brought with me in a gym bag, along with a book and all, I brought a portable urinal.
I have
And
one.
after my treatment, when I went into the bathroom to urinate, I measured my volume. And so I could sort of correlate, okay, how much fullness, how much discomfort I had with how much volume I was holding. And so if, for example, if I was reasonably comfortable at 700 mils, then I said, okay, I'll stick with what I drank today. If I was a little low or I was almost bursting and I had 900, I knew I cut it back. And that was my approach. And it worked very well. In fact, it worked so well, I got complimented by the end of the 38 sessions. They said, we've never had a patient so consistent in volume like you, with, consistent, they didn't know the volume, but consistent, scans. And I said, well, here's what I did. And so that might be one bit of help for you. Okay.
Yeah. Yeah.
In terms of bowels, in terms of emptying, because I'm on enzalutamide and I'm on ADT, amongst the blood pressure medicine and all, I've had issues with constipation. And so what I take, two things. One is, and then probably you've been told this. One is I take Miralax, or the generic.
Oh yeah, I do that. Yeah.
Right? I take it not quite every day, but a few times a week. And I also take stool softener every night at bedtime. Okay? I make sure I eat a lot of fiber. And I don't really like to have caffeine because it's bad for the bladder, but I find having a few cups of coffee, one of which might be, or half a cup might be caffeine. Caffeine is a known sort of stimulant. And all that taken together seems to keep me reasonably regular without any straining. In my case, I have to avoid straining, and I've been okay with this regimen. And I didn't make it up. The doctors told me to try this, and once in a while, I feel I haven't had good bowel movements, and I take the Dulcolax. I might take one the night before or two. Never more than two. Sometimes I might take one in the morning, let's say, in your case, after your scan. But all of this designed to keep regular, avoid hard stools, and all this sort of thing. So that's my 3 cents worth, and hopefully it's helpful.
Yeah, no, especially the volume, controlling the volume, because I always feel like I got to pump this damn bladder up. They tell me they want more than 90% full. Now, the one day I was bursting, and they said, oh, well, you're just about there. You're 90%. And I said, that's about as good as I get. So
there's also, I don't know if they let you use it during that, but there's clamps. I know it sounds crazy,
they gave me a clamp. I have but you know what? They wouldn't let you use my clamp. I bought a clamp through Amazon, but they wanted me to use theirs. It's a wire clamp. Yeah, what the hell? It's no good. And I got to talk to me about that. Your clamp it stinks, And I don't know how good the Amazon one is, but I'm going to try it because it looks like it clamps down a whole lot better.
Make sure that those guys will approve of it first before you pay for it, though.
Well, I get a year to return it.
Okay.
No
I've got something for you, Alan, to say, please. It's not easy. I know that. I remember that it had to be full. Sometimes I had to wait longer than I knew to get into the table. Sometimes I had to wait on the table longer than I expected because they had to wait for the doctor to come and look at everything to make sure that it was okay to go ahead. Sometimes it was so painful when I finished, I really thought I was going to burst. But they assured me you're not going to burst. It's just really uncomfortable. And that's true. One thing I only say, I don't want to go on, but oxybutynin can cause constipation.
Oh,
It is a,
shit.
it's a possible side effect, and I had to stop taking it because I've had all kinds of bladder problems, and oxybutynin turned out to be a non-starter for me for that reason.
And that's what I'm on. I'm on that.
Just, yeah, there's trade-offs for everything, but it's uncomfortable on the table. But I'll tell you one more thing. I had artificial urinary sphincter surgery, and for my real incontinence, and it went very well, except when I finished the surgery, the catheter could not be, it was removed, and I couldn't pee. And they were busy in surgery, and they had to wait so long to come to my aid and recatheterize me that I had 800 cc's in me. And if Alan says he's comfortable at 700, then he's a freak in my opinion. And I think that's
thought those
great.
numbers
At
were
700,
really
I
high
thought I
too.
was going to die. And I called my brother, who's a doctor, and he said, "You're going to be fine. It just really sucks." So maybe, I don't want to say that it's healthy to be able to carry that much urine, but it's probably not as dangerous as it seems like it is to you.
You know what? I tell you what, I wouldn't mind if I didn't leak. It's the leaking. Like one time I
Yeah.
leaked right on the changing room floor. How embarrassing is that? And today I leaked right on the table.
Ellen,
You'll be done
I'm
soon.
gonna move on because we're if we spend about 5 minutes each, we ought to get to everybody.
All right. Yeah, I'm fine. Thanks for all
Let
the
us
help.
know. Let us know,
One thing,
Carl.
Alan Babcock, you may want to come on Thursday to Speaking Freely. You can really let it out there. Big time.
I got Carl next.
I'm gonna jump in and do a promo. For those of you who don't know, we run a Speaking Freely group, which is the perfect group to vent in. It's non-technical. You can't be talking about your treatment or anything else, but you can certainly vent. And we're taking that meeting to twice a month at the request of the gents. It's men only. And at the request of the gents, we're taking it to twice a month, the first and third Thursday. And this Thursday will be the first time. And David, Muslin, and Dr. John will be moderating. So we welcome everybody. Come on in. It's a really good meeting. It can get serious, but we also guarantee a lot of laughs. So please come in, and thank you for raising it, David Muslin.
Carl Van Zee.
Yeah. Hi. I'm in the middle of cabazitaxel. I've got a PSMA PET scan scheduled for Wednesday, which I'm want to give the group credit for pushing me to look elsewhere because my current provider couldn't figure out a reimbursement schedule for that. So I'm happy about that. But I'm really experiencing some bloating. My weight is down, so I'm not worried about that. About this time last year, I was like really bloated all the time, very uncomfortable, but I was about 10 pounds heavier. So my weight's down, but I just feel like I'm just, kind of, I'll be hungry, but then right after I eat, I'll feel pretty bad. And, I'm in the middle of, I just had my third round of cabazitaxel about 3 weeks ago. So, I don't know. I think it's the prednisone, but I don't really know. So does anybody have any remedies or things that they've done to kind of deal with bloating? Okay, thanks, guys.
Don't all talk at once, right? Do you have a feeling it's the cabazitaxel that's doing it, or do you think?
I don't know. It just, last year I was, I got off of prednisone and went on dexamethasone because I was having really bad insomnia from the prednisone. And by the end of the year, I really started to bloat up and my weight was going up and everything. And then when I got off of the dexamethasone and started docetaxel in January with prednisone, all of a sudden I lost 10 pounds and I wasn't bloated anymore.
Yeah.
So, can you cut back on the size of the meal?
Yeah, I do. I mean, I hardly eat anything. You know, my wife's all worried because my weight is down. You know, and I kind of lose a pound or so every day, and then you know, then my taste buds and appetite come back, and I'll eat more, but then I'll feel bad.
Let me ask the doc and the medics who are in the room. Could this be from the prednisone or not? What do you guys think?
Long-term use of steroids is famous for causing things like facial swelling and, you know, obesity in the middle of the body, things like that.
Water retention.
Yeah. So, I mean, probably cabazitaxel too. I don't know. I have never looked it up. Does that cause bloating?
No, I don't. I mean, the question for me is what dose of prednisone are you taking?
10 milligrams.
Now that's not, and are you on ADT?
Yeah.
So, you know, you're basically a little bit higher than physiological. Maybe.
Yeah.
So I'm not so sure, John, that it would, yeah, I don't think you get moon facies with 10 milligrams of prednisone and ADT.
No, these are the people that are on 30 and 50.
Right. I mean, people
60.
really, you know, Addisonians and, you know.
Yeah.
So.
But what about the bloating, Herb? Do you think that could
I mean,
be?
I think that's got to be more a GI. To me, I mean, I'm not a physician. I should tell everybody. John is a physician. I'm not. But you know, I think it sounds GI rather than endocrine.
Yeah. Yeah. I mean, I do have some diarrhea from the cabazitaxel, but it's not debilitating or anything. So, you know, I'm happy that I'm not all plugged up, but it's uncomfortable.
Well, we're going to see what happens. We'll see what happens with the next cabazitaxel. You know,
yeah.
So
if it gets
so
worse,
how long?
that'll give us a clue.
How long does the bloating last?
Well, you know, it's kind of been going on the last, well, I don't know, probably the last month or so.
No, but so you're bloated all 24/7?
It feels like that, yeah.
Huh.
Well, I've got two suggestions for you. The first is, what is your what's your doc saying? I'm trying to remember. Is it still Zhao that you're seeing at Swedish? Yeah.
Yeah.
So what's he saying about the bloating?
You know, he asked me. You know, he's more worried about the diarrhea, and you know, he says my weight is good. It doesn't bother him too much. You know, he's more worried about other side effects and the fact that I haven't been responding to the cabazitaxel. So
Okay, but that's a whole nother issue. I mean,
right.
These docs oftentimes will tend to dismiss these docs will tend to dismiss the side effects, and you know they're focused, and it's not a bad thing they're focused on the cabazitaxel, but they need to address the side effects. And he's an internist, and he should be able to help you. Now, he can refer you to a GI doc. He could refer you to a GI oncologist who might have some knowledge symptoms wise. The other thing is, do you have a palliative care doc on your team?
I'm seeing a rehab oncology doc right now. I'm actually talking to him tomorrow, and I'm going to talk to him about this.
Well, I'm not sure exactly what a rehab doc is, but you know, we always strongly advise that you have a palliative care doc on your team, because the palliative care docs are the guys that are really focused on managing symptoms and quality of life. And especially if they come out of Seattle Cancer Center or Swedish, they're going to see a lot of cancer patients, and they're going to, they may just say, yeah, I know what this is. We've seen this before, and they'll give a little tweak and a this and a that, and it'll go away. So, I mean, don't live with it for another 4 weeks.
Yeah, the
So
only thing
either
I
push.
found, my wife's kind of going through all these cookbooks and everything, because of my appetite and weight loss, and she found something about allspice. So I tried some of it the last couple days, but I haven't really seen any results yet. So
Cal,
the complimentary stuff is great. The complimentary stuff is great, and we encourage it. But there's something going on here.
Yeah.
And as somebody said, you need, hold on a minute, Herb, you'll come in right after I'm done. You've got to get yourself to Zhao and push him and say, no, I'm losing. How much weight have you lost, Cal? 10 pounds?
About 5 pounds or so.
Okay, well, it's enough. And so you got to get to do that, number one. And number two, get yourself an appointment with a palliative care doc this week.
Okay.
Go ahead.
Okay, great. Thanks, Rick.
So, Cal, I just looked at the website for cabazitaxel, and abdominal pain is one of the known side effects.
All right.
So it's not, it may not be so unusual to your doc, and it may be just one of the, and I don't know that if it's a side effect of the drug, it may not be controllable that easily.
Yeah, I'm hoping I won't go through the full 6 rounds, that I'll get in the queue for the Pluvicto after the PSMA PET scan on Wednesday. So I'm hoping that I'll get scheduled for that, in the next month or so. They got a big backlog everywhere. So, you gotta get in there and hope you can get scheduled.
What's your PSA? What's been happening? Just sorry, Dr. John. Just tell us. You mentioned it hasn't impacted your PSA. Can you just update us on where you are on that?
Yeah, it was 31 or something like that before I started the cabazitaxel August 1st, and it's gone up to 62.
Okay.
That's after 2 rounds of cabazitaxel. So I'm hoping it's going to go down. I'm going to get a blood draw on Friday, so I'll know what it is before I see him on the 10th, a week from today.
Yeah, one thing I would mention that, I did cabazitaxel maybe 9 months or a year ago, something like that. You lose track. But I didn't have some of the side effects you're having, but I did find that it had some impact initially in reducing my PSA, but then with time it started creeping back up. So I stopped doing the cabazitaxel and started looking for other alternative treatments.
Okay.
David
Thanks,
Muslin.
Thanks, Dr. John. I just want to bring everybody up to speed with my discussions of either doing possible radiation or possibly some drugs for the enlarged breasts. I forgot what it's called. Having a brain fart at the moment. What's it called?
Gynecomastia.
Thank you for the gynecomastia. So I spoke with Russell Shmulowitz on Friday, and came to the conclusion that let's try tamoxifen first. So I'm on 10 milligrams of tamoxifen, and thank you, Jimmy Greenfield, for that push on last week, and I'll let you know how it goes. So I'm on tamoxifen for right now, and no side effects, and we'll see if I get any results here in the next week or two. That's it.
Jimmy, did you experience any side effects when you started the tamoxifen?
No side effects whatsoever, and it nipped it in the bud. It was very effective. And I had to bring it up to my oncologist to ask for it. And he said, sure, prescribed it immediately. But I know that, some there may be some side effects I didn't experience, but I thought it was really effective. And I hadn't gotten very far along, so I can't say anything about prophylactic versus, treatment of it. But if you haven't got too, it doesn't sound like, David, that you've got too far along. And if you can
No.
stop it now, then you can decide if you want to do anything about what's already there later, I guess.
Exactly. How many milligrams were you taking, Jimmy?
Oh, man, I don't remember.
I think it's kind of a standard dose.
Yeah, there is a standard dose. It was either 10 or 20. I don't remember.
Yeah,
But it was a real standard
anywhere,
dose.
he said anywhere from 10 to 40, and he wanted me to start me at 10 and see where it goes. So
It was probably 10. Yeah. I didn't have any knockers, so, I didn't have to go at it too hard.
Yeah, I'm like an A cup right now.
Yeah, you don't want to go any further, and I understand it well. It's
Okay.
bad enough what we have to go through without adding that to it.
Okay.
This
All
is
right.
an embarrassing illness, isn't it?
Yeah, well, but the good news is I'm here and I don't feel embarrassed at all to talk about it here.
I was just in the drugstore buying pads today from a girl at the counter and thinking the same thing.
Right.
How about Harry? What do you have on your mind today, Harry?
I'm just curious to get some feedback on treatment. I made a decision that I'm a little concerned about. I watch a lot of the meetings on video, and there's been a lot of talk about the triplet type of treatment. And I had recurrence, and I was on darolutamide and Zoladex, and the fatigue just got so bad that it was really impacting my quality of life. So I talked with my oncologist and said, can maybe get off one of these to see if it'll help with some of the fatigue. And so I stopped at the Zoladex, and I'm continuing on the darolutamide, and it's only been, I guess, 8 weeks now. But nagging in the back of my mind was that a poor decision. I know it's not standard of care, and anytime you kind of go off standard of care, there's always questions about whether it's the right thing to do or not. And just hearing all about the standard of care with triplet, I wasn't even doing that. So I'm just curious, kind of where, if anybody's doing similar or been doing for a while, I guess.
How long since your diagnosis now, Harry?
Excuse me?
How long since your diagnosis?
2016 was originally.
2016. Well, I can tell you there are people in this room right now who have been on darolutamide monotherapy and done well and liked it very much. So I don't think you have to be too scared. Can anyone speak to that?
I can. We share the same oncologist, don't we, Harry?
Oh, yeah, I think we did. I don't know if you're still with her, but yeah.
I'm with you. You have Russell, or do you have?
I have Hussein.
Hussein, yeah, she was hesitant to put me on that, but then she finally agreed at the end. But I switched oncologists anyway, and I was talking to Russell Schmulowitz about it on Friday, and he said, you're one of, I think, 2 or 3 patients who are on monotherapy, and he says it's kind of a test for me, but he says all 3 of you guys are doing pretty good. So, it's what works for us individually as well. And I got to tell you something, I feel great being on monotherapy, and my PSA right now is staying low. And if it starts to rise, I'll deal with it then. But right now, to have a great day it's a beautiful thing. So
yeah, certainly.
But I hear your fear though. I understand that. But if your PSA is still low and you're good, enjoy every day, bud.
Yeah. How often are you getting your PSA checked? I'm on every 3 months now.
I do it every month, but I don't get all nuts about it. I just do it. It's just I have it in my calendar. I just do it, and I may get nervous for a minute or two when I see the email and I open up the email, but after that, and by the way, my oncologist said maybe every 30 days is a little too much, but I just want to stay on top of it.
Right. Yeah, it's kind of a peace of mind thing. That's right now. Actually, she had me. I just went off like 8 weeks ago, so I went after 6 weeks for a PSA, and then I'm going to be going back in November for another. So it's probably every 6 weeks, and I don't know if she's going to continue that timeline. But that would probably give me a little bit more, feel better about things, checking
Yeah.
it more often.
6 weeks or every 3 weeks, and you can always go back. And what I learned with two Mets on my ribs is it didn't take much to blast those with SBRT. So I'm not
Yeah, I
that
had the same thing.
yeah I'm not that fearful, and I know I always have this group to come back to coach me. So
Yeah.
it's all about feeling good for me.
All right. Well, thanks. That's good to know.
So, David's not the only one. I mean, Len can talk to it. Peter can talk to it a little bit, although, both of them have tried the monotherapy. And I had a conversation with Dr. Merchant at Bayer on Friday. And I said to it, we've got guys who are doing great on darolutamide monotherapy. When are you guys going to do a trial on this? You need to do a trial in the best interest of the men, because it's easier on the men when they do it. And she told me that we're actually looking at one, and we're hoping to start a darolutamide monotherapy trial very soon. We've been banging on the door for them to do this for Len, 2 years, Len, 3 years, I can't remember, but for quite a while.
A year and a half on monotherapy.
Oh, wow. Okay.
And I want to say that earlier, well, it was last week, actually. I'm supposed to keep this stuff private, so I'm going to have to speak very generally. But I was on an advisory council for a big pharma company, and I was reading between the lines. They're trying to get our impression as to how would men feel about allowing their PSA to rise if they were on monotherapy with a second-line anti-androgen. So I think this is an idea whose time has come. A lot of the pharma companies are going to be running trials with monotherapy on the second-line anti-androgens.
Oh, good to know.
Yeah. Now,
We need that.
if you're going to go on you said you are on darolutamide monotherapy, right?
Yeah, just 8 weeks, really. I should have had my last Zoladex injection 8 weeks ago, so I'm fairly new to it. So.
Okay, so first signs of any kind of gynecomastia or nipple tenderness, maybe you should talk to your doctor about starting tamoxifen.
Yeah, I actually feel really well. I mean, the fatigue, I still have some fatigue, but not like I had before. I've never experienced fatigue like that before when I was on both treatments. So.
Yeah.
All right. Well, thanks, everybody.
Yeah, what I would say, Harry, is if you start to experience any issue with your nipples, I would go for a couple of sessions of radiation up front before it goes, because that's the time to do it. It nips it in the bud right at the beginning, and it's not that dangerous.
Okay.
Although, talk to David Muslin as well, because his guy at Northwestern wanted to give him a lot of radiation, more than we normally hear about, or come back to us, but we can coach you through it. But that's the time to do it.
Okay.
Well, while we're on that subject, can I ask a question? So I'm going to need it probably. The tamoxifen versus the radiation. What does everybody think?
Well, I mean, I can tell you from experience that if you get the radiation early in the game, and Joe Gallo, I think, is on here, and I think he did it. Joe will speak up momentarily. But if you get the radiation right at the beginning, it just nips it. If you are coming in later, then I think it's a toss up, maybe between the tamoxifen and the radiation. Joe, didn't you get it early?
Yes, I had it up front, 3 sessions. And,
yeah, that's what I was going to ask for anyhow.
No side effects at all.
Good. Yeah, I'll ask for that.
Where'd you get it done, Joe?
I was at Fox Chase.
Fox Chase, okay.
But it was almost like a non-issue. but I didn't have to fight with any breast issues at all. And like I said, it was 3 sessions. And I think it was as much as 14 gray total.
For those of you who aren't familiar, Fox Chase is Philadelphia.
Correct.
James Davidson, did you want to have something on your mind tonight?
I think James was going to come back to us next week as a new man, Dr. John.
Yeah, I just sort of joined in at the last minute here.
Okay, I got a little confused there between Jim's and James's, so I'm sorry about that. Mark? I still have Mark.
Yep, you still got me. I want to give you a quick update. For those I've been trying to keep this group updated on my treatments. And so I had a choice between doing a CAR T cell clinical trial, which actually sounded quite exciting as far as the potential for some really dramatic changes and maybe put me into remission. So that's pretty good stuff. They were still in kind of a phase 1, phase 2, so they're still working on dosing. And also the particular process they have is with it's a chemical activator that activates the T cells. It's a similar treatment that they use, I think, for some leukemias and some multiple myelomas. But once you're in it, at least for the remainder of the study and maybe forever, you're going to have to get an infusion by this activator every week, which is by protocol. So as they were doing dosing and as I just wasn't quite ready to be tied to the University of Chicago to be treated every week, I decided to take a pass on the clinical trial. And so instead, I'm going to start Pluvicto this Wednesday. And we'll see what kind of effectiveness we have with that. Hopefully I'll have some good results as some other people on this call, but some other people I know have had pretty good results with Pluvicto. I do want to also say I appreciate everybody's input, and I asked about some of the side effects, particularly damage to the salivary glands and whether it's reversible and how severe it is. And people gave me lots of good ideas, and so I do appreciate that. I will see how it goes, and I will put those into practice. So that's kind of an update of where I'm at, and hopefully Pluvicto will give me, I don't know, 18 months, a year, who knows, 2 years, that'd be great. And then we'll hopefully by then the CAR T technology will have moved along a little bit further, and I'll either go into the clinical trial or I will do something else. I have had my T cells removed, and they are, doing genetic manipulation on them now. But when they are ready to be re-injected into me, I will probably delay that.
Just one quick thing. I really want to thank a bunch of you guys who are on the call right now. The guys who have done Pluvicto for responding so generously to Mark with your input on the
thank you
esophageal side effects. You guys were just great, and I'm going to keep hold of that stream, because if people come back to us later on and say, well, what about the dry mouth? We've got a great stream with some good input from Herb and Mike and Dennis and I don't know, I'm missing people here, but you guys were just terrific, and thank you so much for providing that input.
Yep.
Well, personally, as much fun as it would have been to have somebody in a CAR T cell trial here in the group, I'm actually happier for you having a Pluvicto trial.
Well, it'll be interesting to see, because I did a trial before, if you recall, where it was a different PSMA affinity molecule, and it used iodine 131. That had some effect, had some benefit for me for a short period of time, and then it didn't seem to be really working. So they dropped me out of the study because it just wasn't making any difference. So hopefully the Pluvicto, because it is an approved molecule, and hopefully lutetium will be more effective. We're hoping that that will, have some impact. We'll see.
Okay, let's see. There's not a John here besides me, is there? No, okay.
I'm here.
Huh? Oh, John Madden. Oh, yeah.
Yeah.
You're up.
Okay, well, on Friday, I was going to go see my local doctor about what I thought was going to be discussing the mechanics and schedule for chemo as planned. And 5 minutes in, he says, "Well, you haven't seen your scan yet, have you?" And I said, "No." And he said, the radiologist that read the results said you're all clear. There's nothing to see. And he didn't have access to my original scans, so which were a mess on the PSMA and the other MRI and CAT scans. Like my whole abdominal area was all lit up on my lymph nodes and a couple of bone mets, and my doctor is familiar. That doctor is familiar with those scans, and so he did a comparison side by side. He said your volume is reduced over 80%. I'm going to back out of the plans to do chemo, and I just sat there with my brain spinning for a few hours. I actually got a migraine that day, so didn't know what to do. I didn't know what to do. I had plans to start chemo this week, and so now and all I've been on so far is the Lupron. I started with the Firmagon and Lupron, and diet and a few supplements, and I'm not really clear what to do at this point. I asked him, well, can we still do the chemo and really knock this thing out? And he said, that's really not the route I would go. And so he changed his mind right there, and so we went and picked up our CDs and have asked if Kwan's team will look at them again, or this round of CDs, along with a note on exactly what's happening, to see if maybe we get an opinion from him on this. But really, back to not really sure what to do. I mean, it's great news, but the charts all say hit it hard, hit it early, get rid of it.
Yeah, let me ask you a couple of questions, John. These new scans, were these CT scans, PSMA scans that they compared to the last scans? What were they?
CT with contrast, and I'm on the ADT, so I don't know if I can do a PSMA scan now.
Hold on a second. What type of CT scan? Were they C11 or were these, what type of CT? What were they?
It says CT with contrast, and I'm logging in now to see what they called it, because it just showed up a little while ago. The local hospital that did them had their My Chart offline all day today.
Okay, so let me ask you a couple more questions. These were CT scans. They didn't show anything, but the PSMA scans showed quite a few things. Is that right? Was
PSMA scan done at the beginning of July had, I think somewhere near 10 lymph nodes just hued and 2 bone mets.
Right, and this CT scan didn't show anything, right? Or showed much less?
Yeah, the guy that read it, the lab tech that read it, didn't report anything. He reported.
John, you can't, you're comparing apples and oranges. And I don't know, and who was the doc that said, was it Siddiqui that now says no? Who's the doc?
Dr. Yan at Baylor, and he called up my old CT scans and did the comparison with the new ones, and he said that the reduction in volume is roughly 80%.
Yeah, and when was he comparing those old CT scans to?
The ones that were done around the same time, around the same week as the BSMA.
Yes. Right. So, I mean, he can certainly compare CT to CT and see a reduction. But I would be wanting to compare PSMA to PSMA if it was me. That's the first thing.
Okay.
Second thing is you got to settle on a quarterback. And you know, you're moving around between Quan and this fellow at Baylor and Siddiqui, and it's going to make you crazy. So you got to settle on the quarterback. If you had multiple metastasis, high volume metastasis at the beginning, and you want the longest and the best outcome, if it were me, I'd be doing the triplet therapy. I wouldn't be going on on a short-term result. And you have to make that decision. But it bothers me that, I mean, from what you told us, you did have high volume because there were there was bone and there was a bunch. And this fellow knows that, and he knows the protocol for high volume. And I think if you talk to the guys, we'll throw it out momentarily, but if you talk to the guys who are here, those guys who who went easy at the beginning, they probably regretted it down the road. So, you know, my suggestion to you is settle on your quarterback, whether it's one of the existing ones or whether it's Dr. E, and you've got to stick with them. And don't have one doc second guess another doc, right? Once you settle on your quarterback.
I didn't plan to, and I thought I was going to settle on him because he speaks frankly. I understand him. He was willing to do the chemo, but then right there he changed his mind on the results and was back in a spin as far as which direction to go. I agree. I have to have, you know, I wouldn't want to manage a project. I wouldn't want a project run with multiple project managers putting people in different directions. Yeah, I agree. It's just that it's such a big change, and I mean, I was prepared to start on the treatment this week.
Well, I mean, you've heard us say it before in this group, but if it were me in Houston, I'd have Dr. Estathiou backing me up behind. I'd have her at my back. If she turned around and said, "We don't think we need to do it," I could buy it.
Right.
But my feeling is, it's got to be based on what your treatment should be based on where you were at the time of diagnosis, and you were high volume. And I mean, yes, the LHRH can work wonders for a short period of time, but
okay.
So then when you come, you know, if you jump in now and you start adding things, what we know, and Herb will attest to this because it's based on the clinical trials, is that it shows the triplet therapy shows the best outcomes.
Yeah. Yeah, so this is not that.
We went through this last week. I thought that basically the data are very clear that for high volume disease, you know, yeah, you had a response with something, but you didn't get it. You still, it was 80%. What about the other 20? And who knows what long-term prognosis is? I mean, I would back up Rick and say you need, first of all, settle on a quarterback, and then did you ever ask them, what about triplet therapy?
Yes. and that was the direction, and that's what I was in there to talk about, the schedule for chemo. And then he changed his mind because of the reduction in volume.
Yeah, but that's like sort of that's really not the proof of the pudding. I mean, the proof of the pudding is 5 years from now.
Yeah. Yeah.
I mean, we all know that these things can give a very sharp reduction in PSA and tumor volume. It responds immediately.
No, actually, I don't. I'm just learning. Rick said that this is not uncommon. I thought, okay, well, maybe it is uncommon. Okay, yeah, now I know.
It's the initial response is usually very positive, but then sort of it comes back or stagnates or whatever. And the point is that over time, the clinical trials show that being more aggressive with this regimen prolongs life.
Okay.
And so that's where I would stand.
Yeah, the other thing which our Brains Trust will talk to you about, because they have it better than I do, is that what we seem to see is that some of these cancer cells are more resistant than others. And the cells that are less resistant are the ones that fade away. And the cells that don't fade away are the ones that give you grief over the long term. And I think there's research into that people like Ben and Herb will know more about than I do.
So I should probably push him a little more persuasively to let me do the chemo treatment. And if he won't do it, maybe look at trying to get into Dr. E's queue.
That sounds good, right?
Okay.
I would, but it's not just the chemo. I mean, you're not on a second line anti-androgen yet, are you?
Yeah. No. Not yet.
No, I mean,
but that's yeah.
You're not getting standard of care.
That's the triplet therapy.
Yeah.
Okay. I mean, it strikes me, I've not heard of him before. That doesn't mean much, but it strikes me he's not really on the ball. I mean,
he wants me on the Zytiga, and he said you definitely should be taking that net right now, and I didn't start it yet.
Okay.
What do you think about the yeah, that's well. Has anybody ever tried to use Quan as their quarterback from out of state? I mean, I'd have to do the treatments here.
Well, Les, you can speak up. You the man. At least Les. I don't know who else, but Les, speak on up. I don't see him putting his microphone on, but
hey, I'll speak up.
Please,
this is Henry from from Alabama, and I've had a prostatectomy at MD Anderson, radiation at Dana-Farber, Gleason 9, 8 of 30 positive nodes, and Dr. E has been the best at 3 centers of excellence that I've had the great fortune to engage with, and it's thanks to this group here. And Rick got me in to see her, and I mean, I don't know you. I'm sorry for offering free advice, but you're here, so I guess you'll take it. I'd go see her tomorrow, and there's no question in my mind that she's going to recommend that you start docetaxel and abiraterone along with your ADT. I didn't have bone metastases or visceral metastases. I only had the nodes. And you may have heard the term treatment regret. I regret that I did not push I joined this group late in the game, and I wish I had pushed my treatment team to start docetaxel. I never had it, so I missed the opportunity. And so at least I'm on dual therapy. I would really urge you strongly, in the strongest possible terms, to go see Dr. E, and hopefully begin triplet therapy. Sorry for putting my 2 cents in.
No,
Great.
Thank you.
that's what you're supposed to do, Henry.
Yep.
Les left. I don't know why. Maybe I don't. Is there anybody who has used Dr. Kwan who's in the group today, right now, other than Les? I guess not. You know, I don't want to get into Les's story, but I would have rather he told it to you. I'm happy to connect you to Les. Our own feeling, as we told you last week, John, is that Dr. Kwan is a urologist. He's not a medical oncologist, and we'll leave it at that.
Okay. That's yeah, that's what one of the other doctors said too. Okay. Okay. I'll call Dr. E in the morning, or try to.
If here, let me tell you what to do. Let me tell you not what to do. Let me tell you how to go. If they put you, make sure they understand you're young, you just got diagnosed, you've just been on the Lupron. Make sure they know you came from ANCAN. And if they give you an appointment a long time out, send me a note and I'll see what I can do.
Okay.
Okay?
Okay. Thank you. Thank you.
Okay, I'll move on. I got at least 3 more. Tom?
I'm assuming that's me.
Yeah. Tom
Yeah.
Jacob.
Yeah. And I coming on the heels of the darolutamide discussion, which I didn't realize people were using as a single modality, but I'm on ADT with a essentially double modality with Orgovix up front, and I was with enzalutamide, and I just switched out from enzalutamide to darolutamide, and this is very recent, like last week. My question for the group, if anybody has this experience, have you had any experience with sleeplessness? Because mine seemed to be extreme, and I didn't expect it, but I had 3 nights of almost no sleep at all. And I only started this stuff, I think last Tuesday, switching it out from enzalutamide. And it, as you guys, I'm sure know, when you can't sleep, you can deal with a 1 night, maybe 2 nights, but 3 nights, you start to crack up. And so last night, I finally had a decent sleep, but I cut out the recommended dosage in the evening of darolutamide. I just said, enough is enough. So I'm just curious if anybody else has had this experience with insomnia.
Personally, I was on darolutamide, Tom, and I did not have any trouble sleeping, but your experiment is very telling. And I kind of wonder whether you can take your second dose at supper time instead of bedtime, whether that would be enough time for it to.
Yeah, that's what they're recommending, and I tried to be faithful to it. Take it with food, take it at dinner time. And I, 3 nights in a row, I mean, I felt like a crazy man. I got to get up. And I'm not talking about like half an hour. I was up till, pretty much like 4 a.m. And
So you are already taking it at 5 or 6 o'clock, not at bedtime?
yeah, Yeah.
Oh,
Well, I'm
okay.
not. I stopped taking it. That's my
You stopped
point.
taking.
Is
Okay.
I take it in the morning. I take I forget the dosage, but instead of 4 pills a day, I cut it down. I haven't had a chance to see my doctor yet, but I cut it down to 2, and it seemed to make a big difference.
Yeah.
And you know, it may be my crazy mental breakup or whatever, but I just couldn't handle it at night. And I didn't take it just before bed. I would take it with food at dinner time.
Yeah. Maybe once
And
you get a little bit of rest, you could take 2 in the morning, 1 at supper time until you can check with your doc and see if they're agreeable to that. And it
yeah,
wouldn't hurt to have a sleeping pill in the back pocket just for emergencies, you know?
well, and then
John,
my other question, yeah,
hold on a minute. Dr. John, I got to jump in. I feel an obligation here because, and I'd also like to check in with Peter as well, because Peter was going to tell us Peter said he didn't have anything to tell us, but he was also playing around with darolutamide dosage last week and was going to speak to Schultz today, I think. So we'll come to Peter. Right, let's revert to Peter right after we're done with Tom. But when I spoke to Dr. Merchant on Friday, one of the reasons I spoke to her is because I'm also on an advisory board for Bayer, and I have to sign something about adverse events, which I'm very reluctant to do because we often talk about adverse events in this group.
right?
And I did mention to her that there were guys on this call, and there's at least 2 of you on, I think. One of them may have dropped off, but Peter's on. I don't see the other person. I think he may have dropped off by now, who have been playing around with your darolutamide doses. I will make a statement on behalf of ANCAP. Please don't play around with your doses without consulting your doctor. If you want to back it up, send your doctor a note and say, this is what I'm doing. These are serious, serious drugs. You should not be changing your dose because you think it's one thing or the other. We don't give medical advice, but we do give navigation, and this is navigation advice. Don't change your drug doses without consulting with your medical oncologist, please. We cannot endorse that. You can do it, you can report it on here. In theory, I'm told I'm supposed to report that back. I don't, because I'm not a doc and I can't make the decision whether the improvement, I mean, Peter had an instant improvement when he stopped his darolutamide last week.
Okay, well, let me just chime in. I appreciate what you're saying, Rick, but you know, I haven't had a chance to meet with my doctor yet, and this is something that can really drive you crazy. And you know, when you start eliminating variables and you say, wait a minute, uh, what's going on here? I I'm not. I mean, yeah, I guess I'm experimenting a little bit because I have to stay sane. Um, but you know,
Did
it
you
also
email
begs,
your doc?
it also begs the
Did
question.
you email your doc? How hard did you try to get to your doctor, or did you just say, I'm going to do this and I'll tell him afterwards?
No, the latter. You're right, but
Okay, so all I'm saying is, please don't do that. Let your doctor know what you're doing. I understand why you did it. I understand what you're doing, but we cannot endorse that. We've got to encourage you, tell your doc. If you
okay.
wrote your doc and said, I'm going from 2 pills to 1 pill today, at least it's on the record, it's in your record, you've put it in there, and he knows, and if he thinks it's a problem, or his nurse thinks it's a problem, they'll tell you. When I told Dr. Merchant about this, I could audibly hear a gasp at the other end of the line, audibly. And it is an issue. We don't know what's going on here. It seems very strange to all of us. Tom, were you on the call last week? I can't remember.
I can't remember either.
Okay. Did you listen to the recording? But we went through this in detail. It's highly unlikely that stopping something like an anti-androgen can have such an immense impact, especially something like darolutamide that doesn't cross the brain barrier when we're talking about sleep. Now, this is Dr. John's area, much more than mine. But, you know, I wonder what impact the darolutamide would have had on the receptors in your brain that may have something to do with controlling sleep. This is way above my pay grade. Dr. John?
Well,
Can you comment on
I
that?
am so glad you jumped in and made that point. And if I'm the one that writes the notes for this group, I'm going to make a big deal about that. It just don't do things we shouldn't do things on our own. And if we're so determined to do things on our own, we should at least send them a note that says, I did this on my own and this is what happened.
Fair enough.
I mean, John, what from given your medical knowledge, academic history, etc., as a psychiatrist, I mean, when you stop a drug like darolutamide, how long would it take for that to be to have an impact? And is it likely to have any impact on what controls your sleep? Because it doesn't cross the brain barrier anyway.
Yeah. Wait a minute. Wait. I didn't stop it. I discontinued the evening dose. So let's just be clear about that. I'm not. Okay. I didn't just start.
I think that's clear, but you did, of course, that's very clear. You're right, Tom, but you did actually reduce to a dose that there isn't the slightest evidence is helpful to us. So they have to know. And Rick, as far as your question is concerned, it depends on the mechanism of action of the side effect. So if you take, for example, the example of coffee. So you drink coffee and you can't sleep. And if you stop coffee within a day, you'll be able to sleep better. So there's a direct effect on the brain that wears off very rapidly because it's only got a half-life of 5 hours or something like that. In the case of a drug like darolutamide, which doesn't typically do that, and it supposedly doesn't even go into the brain, it becomes pretty mysterious. But still, I mean, Peter's story from last week was even more mysterious, I think. You know, he was talking minutes and 10 minutes and half hours and things like that. You're talking about the same night. I think it's possible that it could be causing insomnia, and I think it's possible that it had that effect, and I can't imagine what the mechanism of action is.
John, can I jump in?
Please.
So the question I have, Tom, tell me about the series of events. You discontinued Enza. Did you have a washout period before you started taking the darolutamide?
No.
So you immediately took the darolutamide after enzalutamide. So there was still enzalutamide in your system when you took darolutamide.
Correct.
So I'm thinking maybe this is something like an enzalutamide withdrawal.
Oh.
Rather than a darolutamide.
I did. I mean, despite what you say about my concurring with the doctor, I did what I was recommended to do. So
no, I'm just saying.
You might be right. Yeah, that could be.
I'm just saying, given the time period, right? And
Yep.
let's say they both act on similar receptors, only darolutamide doesn't get in the brain, but enzalutamide does. And all of a sudden, you're blocking receptors somewhere where they're not, where they're wearing off. The question for me is, what happens if you didn't, last night you only took one? How many nights?
No. Last night I took none. I took
I mean,
two
I'm
in the
just,
morning.
this is just off the top of my head, just because of the way, John, what do you think? Is it potential?
Sure. It's a great idea. It's a great idea. We just don't know. You
We
do
don't
two
know,
things
and
at once, you don't know which did which. And the ideal solution is that you work with your doctor to figure out which is the problem and what to do.
Well, okay, let me
Sure.
put it a different way. The question I have is the dosage itself. These dosages come from a broad-based study, correct?
Several,
So
hopefully.
do they study dosages themselves, or do they study one particular dosage and then that's what's recommended to the doctor? I
Usually you'll
asked that
see.
because I asked that because with enzalutamide, that was in fact the case. So, I mean, I think it brings up some interesting food for thought. Is where do the dosages? How well have the dosages themselves been studied?
So,
It's very. I believe, maybe I'm wrong, that it's very typical to use high dosages
No,
to.
let's answer you, Tom, rather than what you believe. Let's answer you because there's an academic protocol or trial protocol. Herb, do you want to explain
no,
this?
well, I mean, these doses were established in an early phase trial, phase 1 generally, where they looked, and then phase 2. So phase 1, they'll raise the dose and look at toxicity. And they'll say, well, this is the highest tolerable dose. Okay. And then in phase 2, they'll adjust the dose and then look at response up to the highest tolerable dose. But based on that data, they will establish a dose that's normally not the highest tolerable dose. It's the one that gave maximal effect, right? Because generally they level off. It's sort of like a curve. So that there's a dose response curve, and that once you get above a certain dose, toxicity starts, but efficacy doesn't change. So that's how they establish that dose. And so I'm not looking at the ones for darolutamide. I can't say specifically how they establish this dose, but that's generally how it's done. And so it's not done sort of, oh, let's just use the highest dose we can.
Okay.
Now, if you
Fair
notice,
enough.
Bob just put something in the chat window, which I think is interesting, that enzalutamide has a half-life of 6 to 8 days. So you're now overlapping two drugs with similar actions. And perhaps, I mean, did your doc immediately say switch from Enza to Dara right away, no washout period?
Right.
Huh. Well, I mean, that's potentially you're for the first 3 days, you're getting double dose.
Yeah. Interesting.
We've said to you before, Tom, we don't want to sound like a broken record, but you're using a local oncologist who's not a GU med-onc. And it's so key to have a GU med-onc running your care. And this is a perfect example. He may think, yeah, she may think, Dr. Barnett, whoever it is, may think, oh, it's a great idea. Let's get him off. He'll feel better on darolutamide. But it's got to be done the right way. And these local general oncologists, they're just not up on the game. And this is a perfect example. And the reason you may not have been sleeping well could well be that you're doubling up on the dose here, or you're switching across and there was no washout period. I don't know. I'm not
Yeah,
saying.
no, that's I really hadn't thought about that, and I think those are good points. Thank you.
And we
Now I
just
gotta,
encourage you again, please bring a quarterback, a GU quarterback onto your team. Let them work with Barnett. There's a lot of them out there who work with Barnett, but get a GU med onc onto your team to run your care.
And how do I find them? I mean, locally, or is this somebody who would review things at?
Well, but we talk all the time about how to find a genitourinary medical oncologist. And as you know, your choices in Colorado are not that great. There's that lady whose name I always forget, Elizabeth, whatever her name is, Kessler, who
Yeah.
gets some good marks, some bad marks. But if you go further afield, then, you can go to Chicago, you can go to Houston, you can go to New York, and they will work with Barnett locally. So, you don't have to always see them every time. And some of them will see you, it all depends on the institution they work in and what their protocols are, but that's what you've got to find out. But go to one of the docs that we can vouch for, and they most of the time are not going to have a problem working with your local guy, and helping make the decisions. If your local guy isn't willing to do that, he ain't the right guy.
now I got a question for Rick. It's 7 o'clock. I got at least 2 people left.
Yeah, we'll just keep going, but I really want to hear from Peter because Peter, can you tell us how you're doing and what's happened since you stopped your darolutamide and what Schultz said about that?
Schultz is not involved in this. Antanarakis is, and I met with him.
Oh, sorry, Antanarakis, I beg your pardon.
I met with him today and had an excellent talk with him. And he said I did the right thing, and he would have suggested I did it last week as well. I'm a little uncomfortable talking about this. I feel my privacy is a little bit compromised with this Bayer issue. I mean, we're all very different, and we all make different choices, and we all have different circumstances and challenges. And I really don't think Bayer has a place at the table with us. That's my take on it. Whether my doctor reports this stuff is a different situation, but I don't know. I'm just uncomfortable bringing them into the picture here.
So Peter, you're uncomfortable with the idea that anybody would report our side effects to Bayer.
Right.
And I think we all are, and I think Rick is sensitive to that. And Rick, I think you would agree your obligation is to this group.
That's right. I mean, I've made it very clear that I don't want to be held to a standard where what goes on in this group, we have to report every side effect. I don't believe that, and we're trying to take a look at that legally, but I don't believe I have an obligation to do that. I don't believe that as a peer advocate, I have an obligation to do that. Bayer thinks I do. I disagree with them. And I will also say that anybody else who has signed an agreement here with Bayer has signed the agreement that they're supposed to report adverse events. But this is the first time I've really taken it up with them. But I don't believe we do. And I don't plan to do it. Because I think that we've got to have enough safe space in this group to be able to report what the heck is going on. At the same time, I feel very strongly that we should not be self-medicating, very strongly. And it's just way too risky. And we as a support group cannot recommend self-medication. You do it, you can do it, and you can tell us. But our position is if you're going to self-medicate, be sure you've told your doctor first.
So Rick, there's one thing I think we all recognize is that Bayer has the right to listen to this recording.
That's right.
And if they want to learn about the side effects that are reported at ANCAN, it doesn't have to be through Rick.
That's right. That's right.
So I think that we all benefit by sharing with each other. And you know, if Bayer learns about them, that's not so bad either. If they're if it's reportable.
Right, but there's just too many variables going on, and there's no definitive studies. I mean, we're mixing and matching powerful, potent drugs. I mean, darolutamide is one of the most potent and powerful of them. I've been on it for 15 months, almost a year and a half. It has, you know, my guess is it's got cumulative effects. I mean, this is not something that just, you know, it's not the same as when I first started it. And then I'm mixing it with Keytruda, and God knows what. I mean, you can look up and see if there's any indication this or that or the other thing, but we're all different. We all react differently, and we don't know. Nobody knows all these things, and even the doctors are guessing. So you report what's going on, and they're guessing too. So Dr. Antanarakis totally agreed with me that I did the right thing, and he continues to agree with me. But he's guessing, you know, what causes this and what causes that. Nobody knows for sure on some of this stuff. I mean, we're the ones, you know, sometimes that suffer some side effects that come out of nowhere. And, so I'm just saying, even if Bayer, I mean, Bayer's not going to be able to draw conclusions from this and that. I'm the only one that seemed to have gotten a bad reaction to Orgovix. I've never met anybody else that got that. Came out of nowhere for me. You know, I talked to Schultz about it. He said, "Stop it, get off of it." And sure enough, I stopped it, and it cleared up. But you know, nobody else has experienced that. So
Peter, what was the bad effect you had from Orgovix?
I had an extreme, I don't know if you want to, I guess you could call it anaphylactic reaction. A lot of big rash, itching. I mean, I couldn't sleep. I was just scratching my back of my neck and my back constantly for 4 days. I was changing soaps. I was changing shampoos. I didn't know what the frick was going on. And that's what it was. But nobody else has had that effect that I know of. I called Orgovix and they said they'd never heard of it. I called the what do you call the FDA people to report that stuff. They didn't seem to give me much traction with that either. So anyway.
Yeah, but you know, they're not there for traction. They're there to gather the information which they then feed back to the company. It's just it's been explained to me there's a public health obligation here, and that's why these adverse events get reported. You know, I'm still not sure I agree with it because I don't want to breach the safe space that we have here. And so I'm not going to be reporting stuff. At the same time, I encourage all of you to report it. I encourage Tom Jacobson to report it. I encourage you to report it. That soon after you took pembrolizumab with darolutamide, you had severe fatigue, almost confusion, and when you stopped, it went away. These are important things that we need to feed back. They really are. And so I just ask you in the same way I was asked, to consider the public health. They're not going to solve the problem. Dr. Antanarakis is going to solve the problem for you. And if he thinks you're fine stopping the darolutamide whilst you get the pembrolizumab, go for it. Are you on, you're not on a LHRH any longer either, are you, Peter?
Haven't been on for 15 months or more.
Right. So you're basically just, so this now will turn into just a pure pembrolizumab medication for you.
For now, yes.
Does anybody know if darolutamide has been trialed with what do they call those all those pembrolizumab studies, those Keytruda studies? I can't remember the name of those that series of trials.
Keynote trials.
Keynote, thank you, Len. Keynote. Anybody know if daro's been tried?
I doubt it because it isn't used that much for prostate cancer. It's not that common for it.
Yeah, I doubt it too. There's just no data.
So, Rick, what I'd
I
like to do.
don't want to drag this on. I'm just saying we're all very different. I mean, it's like you know, we're our own test tubes here. It's quite a game.
I think what I'd like to do now, if it's okay with you, Rick, is to just make sure that guys that haven't had a chance to speak are not in an emergency situation. And if they're not, maybe we could just pick it up again next week. Is that okay?
Or we're here, we can just do it.
Or we could just do, what should we do? It's Tony and Al on my list.
So I'm happy to keep going if they're willing to hang in. We had a very big group tonight as well, guys. So
yeah,
don't feel badly. I mean, there was almost 50 people on the call tonight. So Al and Tony, are you willing to hang in and we'll talk to you?
Yes. Yeah.
Yes, I am.
Okay, let's go.
Tony?
I've got a quick question regarding the PSMA PET scan. My surgery prostatectomy was July 8th, and 7 weeks out, I had the first PSA at 0.39. And then 4 weeks later, last week, I had another PSA test, and it's 0.38. So it went down just a touch. And my PET scan is scheduled for October 12th, a couple of weeks away. And I didn't know whether it might be, I know Rick had mentioned you'd need to be at least 0.55 for it to be detectable for recurrence. And I also recall, I think it was in last week's meeting, they had suggested maybe using Aximum for the PET scan. And I had suggested that to Dr. Van Veldhuizen, and they used gallium, and they said it's more effective in being able to detect smaller amounts. So I didn't know whether it might be good to delay getting the PET scan or going ahead with it because of the small number that I have for the PSA.
It's a great question. It's a really good question. I think you're out of range where an Aximum scan would help you. And you got a response out of your surgery, but not a complete response. And your doc is hoping your PSMA scan will point out exactly where the remaining cancer is, but you may get a false negative result. You may very well. In other words, it might say there's nothing there, but there's something there that's microscopic or too small to see. As far as the question of whether to wait, that's a really tricky question. I've heard the experts here advise guys often to wait until a PSMA scan will give a result. And even though it's an anxious type of waiting, nobody likes to sit there and see their PSA go up. It's an anxious kind of waiting, but I've heard that mentioned on a number of times. In addition, you're probably also on Lupron or something like that.
No, I haven't started anything.
Nothing. You're not on anything else? Okay. So I don't know. What do you guys think? Should he wait, or should he get his PSMA scan with a PSA of 0.3?
It's 0.4, but I don't know. Dr. Van Veldhuizen would like to do it. That's what you're getting the picture, right?
Right.
I would ask him, saying, I've heard that maybe it's not going to, we may get false negatives at this level. What do you think? I would get his advice.
All right, that sounds good. Thank you.
I was in a similar situation, and my oncologist said, we're going to do it anyway.
Yeah, I bet he does. I bet he does it anyway. Because
Yeah.
what's going to happen? So you're negative and your PSA is 0.39, and then you'll wait. And if then it goes up to the point where it needs action, they'll do another one.
Yeah.
To be proactive, though, perhaps, I don't know whether I should get a pelvic floor radiation treatment or not.
Well, that's exactly the next treatment question. Yeah.
I think
So,
that's another. Ask
This
him
is the
again.
game of probability. The lower your PSA is, the less probable it will be that the scan will pick something up. It doesn't mean that you might find something at 0.38 or whatever it was, and you might not. Maybe the probability is 35, 40%. If you wait longer, 0.5 or even higher, the probability of detecting the lesions goes up, maybe to 65, 70%. So as long as your insurance pays for it, I think I might go for it. I might try it. And you get approval first. And then, but conventional wisdom is that salvage radiation therapy should be done between PSA of 0.2 and 0.5. That's been a long-standing standard of care. So if you want to let it go up to 0.5, get the test, and if it's negative, get the salvage radiation therapy, because that's the time to do it. If it's positive, then you'll see where the lesions are. Maybe they'll even do SBRT.
I'm concerned about the aggressiveness of it if it really would move.
What's your Gleason?
9 with a grade 5. And
Yeah.
I've got a check 2 gene mutation.
Right. Yeah. So
I think one area that you can be comforted by is that your PSA has barely changed in the last month. Did you say, is it a month between the two tests, Tony?
Yes.
Yeah.
6 weeks.
So
Yeah.
I think that, in a month, 6 weeks, it's barely changed. And that's a really good sign. That's a great sign. We have guys on here who will tell you that they've gotten results at less than 0.4. And we've got guys on here who will tell you they didn't get a result at 0.6 or 0.7, but then it came in. So, everybody's different. To some extent, it depends on how clustered, wherever that PSA is coming from, how clustered it is. The more diffuse it is, if you had, God forbid, 10 spots and they were all making 0.38, it would be diffuse and it would be tougher to see. If you had one spot making 0.38, it's likely to show up. So we don't know how diffuse it is. Do you understand? Do you follow my logic here?
Yes,
And
very
so,
much so.
you can, my guess is Dr. Van V is going to say, do it. If it were me personally, I probably would hold off until it was at least over 0.5. But that's just from what I've seen and what I know, and God willing, you'll do it, and we'll see exactly where it is. But if we don't see anything, then I probably would hold off until we do see something. I wouldn't, if we don't see anything, I wouldn't, if it were me, I wouldn't dive into adjuvant salvage radiation and hormone therapy. I would wait until I can see where this is coming from, so we can know whether to treat it there or not. You're going to get the salvage radiation to the pelvic girdle is what you're going to do. And hopefully to the whole pelvic girdle, not this rabbit's ears stuff that they do. But the whole pelvic girdle, and you're gonna get the hormone therapy, but we don't want to start that until we know where this is coming from.
Okay, good. Thank you very much.
I don't know if that all we've done is confused you even more, right? Sorry.
No, that's fine. Thank you very much for your input.
Al?
Hi. Oh,
Hi.
good. The camera came back too. Good.
Yep.
I'll just cut right to the chase here since it is now almost 10:30. Rick and Herb already know I've already sent them what I've been offered by Dr. Belusic at University of Miami as a phase 2 clinical trial, which just kind of came out of the blue last Saturday night. I have had a brief meeting with him today just to go over some of the logistics, and he told me that there's only like 4 slots left in this trial, and I had to make a decision pretty quickly. I'm going to meet with him later this week to go over the details, and if all agrees, sign the paperwork. I guess my question is, what should I be asking? What should I be looking for in doing this instead of doing chemotherapy, which was the other thing that was on the table right now? The trial is SRF 617, if anyone knows what that is.
Right, and you've never done chemo, correct?
I have not done chemo, correct?
Yeah. Herb, do you want to?
So I weighed in. I wrote to Al and I said, this looks promising. They've reported some promising results with this combination of it's an antibody that it's the adenosine pathway, which we talked about as being promoting cancer growth, and this is designed to block that pathway. And they have reported some positive results in several different kinds of cancers. And my own sense of it, Alan, you got my email, was, well, if it doesn't work, you'll get chemo.
Right. Yeah, I saw your email, and I agree with that. I wanted to present it to to the group here and see if anybody else had any other comments on it.
Well, what about the opposite argument, to play devil's advocate? If chemotherapy is clinically indicated now, why should you be doing a trial instead of the standard clinically indicated practice? Antibody therapies have not been very good with prostate cancer, so why should you not do standard treatment? Herb, what's that?
Well, I mean, that's a good question, John. I think it's really you're right. Standard of care would be chemo, except for the fact that we all know that chemo is pretty brutal, and this is not going to be so brutal.
Well, that's the answer right there.
Herb, we've got to be consistent. We're sitting here telling John about triplet therapy and why, and Al Latimer's been an ABC guy, and we just lost an ABC guy, and we didn't. I'm sorry, we didn't.
But that's true.
We didn't have to lose him.
Hey,
It's
you're right.
It's
mean,
it's an expression. It comes from, it's a Chuck Ryan expression. That's where I got it from 13 years ago. And you know, ABC guys, and we've had many of them here, they don't do that well. And there's a reason why you should do early on chemo. And we know it now. 13 years ago, it was revolutionary, and not many guys were doing it until the very end. But I have to agree with Dr. John, and because I want to be consistent. Why do a trial when you haven't been through the standard of care?
Yeah, I've heard this, guys. I agree with you. Maybe I think I agree. Rick just
You know,
changed my mind.
I mean, let me just say, Al, I do believe that if Steve Saft had done his chemo early on, he'd still be with us today. We couldn't get to him in time, and his PSA got too high, and by the time it got to that high, it had too much of a grip, and there wasn't anything we could do to save him. And that's really that's why we know now chemo works. Triplet therapy works, chemo works early, and the longer you put it off, the weaker you're going to be when you come to do it. This combination of drugs, what are the two drugs? One with an E and one with a C.
There's 3 different drugs in that. I don't have their names in front of me.
Yeah, help me remember.
There's 3 different drugs involved, right?
Right, but this is, you know, the 2 of those drugs are what the guy in
Van Veldhuizen,
Van Veldhuizen's guy is doing, and
it's the
and
same
it's
trial with a different variant.
Yeah, and it's not working out for him.
Well,
and what
also,
we like.
Go ahead.
Go ahead. No, I mean, I can only tell you, if it were me, I'd jump into the chemo. Would it be docetaxel or Jevtana? I'm not sure. Given where you are, your age, I mean, it should be docetaxel, but if it was Jevtana, that wouldn't be the worst thing in the world. But I think that you got to do it. And putting it off, I mean, we saw what happened with Carl Foreman, another ABC guy. He's not on tonight. But when he did get into it, it had an impact right away. Is it coming back afterwards? Yes, but I wish he would have done it earlier.
So this is only a phase 2 trial. So if I do the chemo, maybe someday it will be a phase 3 or even approved.
Exactly.
And so I don't really see, I kind of agree with John and Rick. I really need to go ahead and do what's actually on Friday, that was the plan. It changed Saturday night when I got that email from Blusick.
No, well, after listening and the arguments on both sides, Al, I think I would be with Rick and John and say, yes, the evidence that we've seen in this group is that earlier chemo is better.
No, in my case, it's not all that early since I've been doing this 27 years. But back then there was that would be unheard of to do chemo early on. And besides, I got 20 years out of ADT alone. 20 plus years.
Yeah.
How early is early for the chemo? When you talk about early, get at it early, what are you talking?
It
Like
can be
first
within
line
6
drug?
months.
First line?
Yeah, first line. When you're diagnosed, you think it's already spread. You do the triple. That's the thinking these days, right? Like they do in breast cancer.
Yeah, I mean, not when you're immediately diagnosed, but if you're immediately diagnosed and the disease has spread and we see more than 4 or 5 spots, yeah, it's time. Or you know, if there's recurrence and we see 4 or 5 spots, it's time. If we see 1 or 2 or 3 spots, it's not time. I can't remember without looking.
No, I'm just getting started. I hit point 1 in August and going from there. So, I met with the rad-onc and all that fun stuff. And I'm seeing Dr. E on the 27th of this October here. So.
And what was your original treatment? What was your original treatment? Prostatectomy. And how much? And have you had a PSMA scan?
No, I'm having that
okay.
Wednesday.
So if you're seeing Dr. E, she's going to guide you. She knows
right, that's what
as good as
I was
anyone.
just curious to what early. I mean, before. I mean,
right.
I'm
but
just wondering.
To come back to
Al, let's come back to Al and say chemo looks like the better bet right now because we know it works.
Hey, this question is for Al. How is your PSA?
How's my PSA? Well, as you know, I had lutetium last year, and my PSA at the low point was 1.5. Now, 6 months later, it's 30 something. So it has really taken off since the lutetium. My PSMA PET scan right after lutetium was basically clean. Now I've got lymph node involvement in multiple locations, so it's all progressing and fairly rapidly.
Chemo.
If it were me, I'd hit it hard.
So I guess my question is, why would Belusic even throw that into the loop?
Oh boy.
He needs more bodies.
Because he needs bodies for the trial, and it's disappointing that's what he's doing.
You really think that's true?
Yes.
Sure.
I do. I mean, they all these academic docs, but most of these academic docs have a conflict of interest. And they don't want to admit it, just the same way that, the urologists want to do surgery. The guys who are in academic practices want to do research. And I don't know what his connection is to this trial, to the drugs, anything else, but it is an issue. And we in this group try to keep the docs honest. And I don't know why he would present it to you. I mean, and I would go back and you can say, the guys at ANCAN say, why aren't I doing the protocol? Why are you pushing me into this trial when I've never done it?
So Belusic knows you, right?
He knows us.
Yes, he knows you. So, okay, well, I really appreciate your take on this whole situation.
Okay, guys, including my bosses, it's my job to get this meeting over with. So if there's no urgent situations, are there?
No, and when Dr. John said his boss, he wasn't referring to me. He was referring to somebody. He was referring to my dear friend, his wife, Ray.
I was referring to you guys.
John, stop the recording if you're.
Okay, I will end the meeting and I'm about to stop the recording.
Yeah, and you did.